لا حرام 10 عرب كنا أكثر
صح. Okay. Today's lecture is going to be the first of two lectures covering the topic of the adrenal steroids or corticosteroids. In today's lecture, we're going to introduce the basic concepts related to both lectures, mineralocorticoids and the glucocorticoids. And tomorrow we'll be just finishing up the topic of glucocorticoids. I guess it's going to be the most important lecture of the whole system. Tomorrow's pharmacology lecture in the morning. Okay? And you will know why that is. Right. Start with the topic of mineralocorticoids, and as I have already done in the previous lecture, I should go to the basic concept of the regulation of this system, which starts again in the hypothalamic pituitary axis. And here we are talking about the CRH being a stimulator for the synthesis and release of ACTH. Right? Just an off-label note here, which is very important for you clinically. And that is the action of the CRH is to cleave this precursor, which is the pro-opiomelanocortin. Right? And that will give us three products according to the name. The cortin part is the one that's responsible for the actions of ACTH. Right? The opio part is going to produce a chemical or a hormone called beta-lactotronin. And from the name, opio, it's related to what? Opioids and endorphins. So it's thought to be responsible for the release of endorphins in your body. And finally, the melanocortin, which is responsible, or which will produce the MSH. And that's important clinically in one particular note, which is what? Why is that important? To understand that the cleavage by CRH is going to produce these three hormones. Yes.
مع ال ACTH لما يزيد ال MSH فبصير الميلانين كتير و pigmentation.
Exactly. So one sign of the increased ACTH, okay, production could be the hyperpigmentation of the skin, certain parts of the skin, of course, and the mucous membranes, which is again related to this action of CRH on the cleavage of pro-opiomelanocortin. Now, as we know, the ACTH action will be directed into the adrenal cortex, and that's to stimulate the release of three particular hormones, mineralocorticoids from the outer layer, and the glucocorticoids from the middle layer, and the weak adrenal androgens coming from the innermost layer of the adrenal cortex. Okay. Now, as we said previously, that the whole system aims at having multiple checkpoints of regulation, and one checkpoint is the negative feedback. Right? So, which of these will exert a negative feedback on the secretion of ACTH? Exactly. That's important. Important why? Because when we talk about the mineralocorticoids, the major regulator of mineralocorticoid secretion is not ACTH. Okay? And the major regulator of the function of ACTH is not mineralocorticoids, it's rather glucocorticoids. So the major source of negative feedback are the glucocorticoids. Okay, now I shall start by talking about these drugs in the hypothalamic pituitary axis and how we use them clinically. And we will start with CRH. What do you think it's going to be used for? The general principle is that it's going to be used for diagnostic purposes. Where do you think that's possible? If you take similarities from previous lectures. Secondary and tertiary adrenal insufficiency, for example, you use the CRH for that. But actually, in clinical practice, that's not the case anymore. We do not use CRH for that purpose. And it's going to be weird for you to know that the use for CRH in diagnostic purposes aims at one thing, which is when you have a patient with an increased ACTH levels in the plasma. Okay? So this patient has a level of ACTH that's above the normal level, expected level. We use CRH in this case by giving it by IV injection and look for something to differentiate between the Cushing's disease, not syndrome, which is an increase in the glucocorticoid function due to a pituitary disease, against an ectopic ACTH secretion. Now, what do you think will happen if Cushing's disease was the reason for the increased ACTH? When you give CRH? Yes. What will happen is that the level of ACTH will be increased. And that makes sense. You have a pituitary adenoma secreting ACTH, you are stimulating that with CRH much more, that will increase the level of ACTH. On the other hand, if you have an ectopic ACTH secretion, what's going to happen to the level of ACTH? Little to no change. But one point is, but why is that? You're giving CRH, it's going to go to the pituitary, and it's going to lead to increased ACTH production.
Carcinoma inhibits the pituitary.
Exactly.
Feedback.
So the negative feedback. Negative feedback regulation at this point is going to be inhibiting the regular and the normal levels of ACTH production from the anterior pituitary. So when you give the CRH, there will be little to no change in ACTH levels. Okay. Now, ACTH is going to be also the same. Going back to the fundamentals we talked about at the first lecture. This hypothalamic pituitary axis is mostly for diagnostic purposes. And here, where do you think we should use it? To differentiate between what and what? ACTH. Thyroid? Exactly. So it's going to be to differentiate between the primary adrenal insufficiency versus the secondary adrenal insufficiency. Okay? The primary is called what? Addison's disease. So in this case, what shall you measure in the plasma? Always look to the downstream.
Aldosterone. Glucocorticoids.
Exactly, which is represented naturally by
Cortisol.
cortisol. Okay? So what we will measure is the cortisol level in the plasma versus time, and we start by giving the ACTH IV. There are some formulations we could give by the intramuscular injection, and then we measure levels of cortisol over time. Okay? What's going to happen if it's a secondary pituitary cause for adrenal insufficiency? That cortisol level will be increased, while if it's a primary Addison's disease, there will be no change in the cortisol levels. Okay, type. That's cool. Now let's get to the corticosteroids, which is the meat of this lecture and the basic principles which we'll cover today's and tomorrow's lecture. Now the first thing I wanted to highlight, which is very important, and it's a distinguishing factor between the adrenal cortex hormones and other hormones from other endocrine cells. And that's the fact that adrenal cortex cells store only minute quantities of the hormone. What does that? Why does it make any difference?
Then the other cells can't store.
How does that affect us clinically? That's it.
It will be inhibited if you give.
Okay. So any kind of removal of the adrenal gland, you're going to get into a sudden state of acute adrenal insufficiency that's very severe. And the other thing that's important, that the level or the rate of release of the hormones is governed by the rate of biosynthesis. There is no discrepancy between biosynthesis and release. And this is, again, distinguishing that from the thyroid gland, where the rate of biosynthesis is totally different from the rate of release. Okay? And that's why ACTH plays a major part in the process of regulation of cortisol levels during the day, during stress, or during any other stimuli. Okay? The second part I wanted to talk about is the mechanism of action, which is, in a way or another, is something closely related to the function of the thyroid hormones. And that's because both of these structurally are similar. Now, as you know, these are steroid hormones. So what you expect is that the receptors will be not nuclear, cytoplasmic. Okay? And you would not expect that there are any plasma membrane receptors, ideally. And this is exactly what happens with the glucocorticoids or steroids and mineralocorticoids. They have their cytoplasmic receptors. Romeo, تعال انزل تحت. انت وحاط كمان الهيدفون انزل لتحت. انت اقعد. So we would expect that these hormones have their receptors located within the cytoplasm. And one important thing about the receptors of glucocorticoids and mineralocorticoids, where do you find them? Let's start with glucocorticoids. Where do you find them in the body? What else? Actually, glucocorticoids receptors are located or distributed throughout your body, starting from the brain and going down. There is no tissue that does not have glucocorticoid receptors. On the other hand, for the mineralocorticoid receptors, they're going to be located mostly in the kidney and other excretory organs like salivary glands, the gut, and so on. Okay, because their function is related to excretion. So these are the receptors. So the first step in the process of corticosteroids function is what? Is passage of the hormone into the cytoplasm and then binding to the receptor. And the second step will be related to what I'm showing in this picture by showing two receptors. It's the fact that there should be a dimerization of these receptors bound to the ligands. Okay, this is an important step in the activation of steroids. Now, once there is a dimer of ligand plus receptor, they're going to then go and translocate into the nucleus. And here's something important. When they translocate into the nucleus, they're going to act where? On DNA, particularly on certain sites called the steroids response elements, okay, within the DNA, and they will act as transcription factors. Once they act as transcription factors, then effects will be produced. Again, why is that important for us clinically? It's not different from any other hormone. The effect, the onset of effects, what will it be? Exactly. It's going to be a slow, delayed effect that's not immediate. And that's very, very important for the function of corticosteroid. You won't give a corticosteroid as a drug and expect to have an effect within 1 or 2 minutes. Okay? Ideally, the effect should be not immediate. And that brings about another thing. Why is it not immediate? Because it's acting on the gene expression of certain things. Okay? So if I have a drug, cortisol, I gave it to the patient, and let's say the half-life of that was 3 hours. It was eliminated from the body. Does that stop the effect of cortisol? Exactly. And here is something about the corticosteroids, the glucocorticoids and mineralocorticoids. It's the first time we're going to deal with a discrepancy of half-life, which is the plasma half-life versus the biological half-life. The plasma half-life might be very short, but that does not matter. Because what matters most is the biological half, which means that the effect is going to be more prolonged even after the elimination or removal of the drug from the plasma. You got it? This is is very important as a distinguishing factor for corticosteroids. Now I wanted to end this topic by saying or adding another thing, which is very interesting and was recently introduced. As we said, the effects are not immediate, so they might take 2 to 3 hours to get any effect. But some of the actions can be done within a few minutes. Okay? And that was really intriguing and interesting scientifically. So when they started studying that topic in more detail, they found that no, corticosteroids could also have a certain subtype of plasma membrane receptor, and some of the effects that are immediate are derived from binding to these receptors. Okay? Most of these receptors are G protein coupling receptors, which is weird, knowing that our historical consensus is that steroids, they're not going to bind to a plasma protein receptor. So it did not make any sense. But it was discovered, and there is a new class of receptors for corticosteroids. They are located within the plasma membrane. Okay, but clinically, the most important thing is that most of the functions we need from glucocorticoids are not immediate, and you cannot rely on the fact that they have cell membrane receptors. Okay? So keep it in mind. Now, the other thing which is important about glucocorticoids and mineralocorticoids, or in general corticosteroids, is what's shown here. This is from your book. And as you can see here, that most of the natural and synthetic mineral and glucocorticoids have cross-reactive functions. Which means what's shown in red is the anti-inflammatory function, which is the glucocorticoid function. And in blue, it's the salt-retaining function, which is the function of mineralocorticoids. But it's very interesting that most of these drugs have both effects. And this is something you have to take into account when you give certain drugs for certain diseases. You have to keep in mind that these steroids have a predominant effect, but in the same time, they might have an added or an extra effect by cross-reactivity with the other kind of receptor. Okay? And you will see how that's important clinically in tomorrow's lecture. Type. Now, luckily enough, since these are not protein hormones, these are steroid hormones, so they are mostly already available. Okay? And with actually very high bioavailability for most of these natural and synthetic compounds. That's great news. So you can use them anytime. But at the same time, they are also available in several other routes of administration, which might add another level of complexity when you deal with them as a physician. But you will find out that such invention of multiple routes of administration for these drugs was a great advancement in our use of corticosteroids in clinical practice. And if you go back to what we discussed already previously in bronchial asthma lectures, we said that this is a very major advantage of corticosteroids. Now, once they are given orally, absorbed, they travel through the plasma bound to the plasma proteins in more than 90% of them, and then they are metabolized by the hepatic microsomal system. Okay, so again, we will go back to the idea of inducers versus inhibitors of that CYP450 system, and then they are excreted renally. As I'm showing here, it's almost universal for all the corticosteroids we're going to talk about, whether today or tomorrow. So just keep these principles in mind. Type. Now, we had the natural compounds. For example, in the glucocorticoids, we have cortisol. And in the mineralocorticoid, what's the natural compound? Aldosterone. But if you go through the textbooks, pharmacology or medicine, you will find 10 other synthetic compounds or derivatives of these natural compounds. So what's the advantage? And you have to understand that synthetic derivatives versus the natural ones are or have a higher oral activity or bioavailability. Okay? So you're going to use them with much more ease and confidence. They are more selective, which means what? That the cross-reactivity is going to be less. So if you are given resistant to metabolism by the CYP450 enzymes, okay? And that's related to their chemical structure. So drug-drug interactions will be of less importance than when you give the natural compound. And finally, they are longer acting. And maybe that's related to the fact that they are more resistant to metabolism. Okay? Right. Let's start with aldosterone, which is our major topic of the lecture. The major mineralocorticoid. And the function of aldosterone, as we said, is not highly regulated by ACTH as much as it is regulated by the renin-angiotensin II system. Okay, so if there's renin-angiotensin II, that's going to activate the production of, or secretion of aldosterone from the adrenal cortex, which will go and function mostly where?
The kidney.
In the kidney. Where exactly? The distal tubule and part of the collecting. Like, but what's the major regulator of the renin-angiotensin II?
Volume.
Exactly. It's the mean. We don't talk about volume. It's mostly the functional part is the pressure.
Pressure, okay.
And that's why they are called baroreceptors in your body. So the mean arterial pressure is the major regulator of this system. So what should happen to activate the renin-angiotensin? Decrease in the blood, in the mean arterial pressure, and that will activate the release of renin-angiotensin II and aldosterone. Correct? So that means aldosterone should contribute to what? Increasing the blood pressure or restoring the normal blood pressure levels. How does it do that? Just a quick reminder that the effect will be mostly on the distal convoluted tubular cells, acting on the sodium channels, on the luminal membrane. Sodium will get in and it will then be exchanged for potassium at the vasolateral membrane through the sodium-potassium ATPase. The function of aldosterone is going to be to go down and activate the gene expression of these receptors, both the sodium channels, the sodium channels and the sodium ATPase pumps. Once that happens, what's going to happen? What's the effect?
More sodium.
You're going to get more sodium to be reabsorbed, okay? And since water and sodium are soulmates, you're going to have both of them at the same time. So there's sodium and water retention, and since potassium will be shunted back into the tubule, into the lumen, it's going to be lost. You lose potassium mostly accompanied by hydrogen, and that's why you will have potassium and hydrogen excretion. So if we take that from a clinical point of view, if you compare the deficiency versus the excess of aldosterone, what's going to happen with the deficiency?
Hyper.
First,
Hypotension. خلص.
the first, let's talk about sodium. What's going to happen to the level of sodium in plasma?
Decrease.
So it's hyponatremia, and that's going to be coupled with hyperkalemia and acidosis. Okay? Because there will be more attention on potassium and hydrogen. On the other hand, if we have an excess of aldosterone, that's going to lead to hypertension because there's more sodium and water retention. On the same time, we will have the hypokalemic alkalosis due to the loss of potassium and hydrogen. Great. The bad thing is that, as you would expect, aldosterone is not available pharmacologically, although it's the most potent mineralocorticoid. Okay? It's not available pharmacologically because of one thing, and that is it has a low oral bioavailability. Which means what? Low oral bioavailability. What? It has two facets. When you say low oral bioavailability, first, it's the poor absorption, and the second thing is that it might also go or undergo the first asymptotic metabolism. And that's why aldosterone is not used clinically. Why is that? Because we cannot regulate the dose. How can I regulate a dose when I don't know how much will be absorbed and how much will be metabolized? Okay? So that's why we needed to introduce a new synthetic compound that has the same functions of aldosterone. Again, it's going to be even worse, regulating the dose of aldosterone. Not related to bioavailability, because bioavailability will be 100%, but the dose regulation will be very bad, particularly because of the metabolism. Type. We got a synthetic compound, or synthetic derivative, that's going to be more highly active orally, more resistant to metabolism, and has a longer duration of action, but most importantly, with less glucocorticoid function. And this is fludrocortisone. Fludrocortisone is a potent one, and as you will see here in this, the activity of fludrocortisone is about 125 times that of hydrocortisone. Hydrocortisone is the nature of cortisol, okay? And we always measure the functionality and the potency of these drugs against the most natural one, which is hydrocortisone. So fludrocortisone is very potent, but the bad thing is that it's not devoid of glucocorticoid function, okay? So when you give it, what should you expect first? What should you take into consideration most? The side effects that will come with such glucocorticoid function. Okay? Keep it in mind. Now, where should we use it? Is it the next one? Fludrocortisone, where should we use it? It's a mineralocorticoid. شباب الانdocrine يعني it's the only thing that you do not need to memorize anything. You give something if there is deficiency. You give an antagonist when there is excess. Seriously.
Yes.
Okay, and that, when does it happen mostly? So, replacement therapy mostly in the primary adrenal insufficiency. Okay? Primary adrenal insufficiency, which is the Addison's disease. Okay? So there's a problem within the adrenal cortex that it's not producing enough aldosterone. There's another disease, I'm not sure if Dr. Najda told you about, which is the congenital adrenal hyperplasia. حكيت لكم عنه؟
حكيت عن hyperplasia.
يلا مين يحكي لي شوي؟
هاي مجد.
احكي على الموضوع. لا congenital adrenal hyperplasia. مين بيعرف؟ لا هذاك المنطق الإندوكراين مين بيعرف؟
يصير في شيفت
production biosynthesis. So it's a problem with the enzymes involved in the biosynthesis of both glucocorticoids and mineralocorticoids. It's going to happen, it's going to lead to more production of androgens, particularly testosterone. So what's the major feature of that disease? It's going to be symptoms and signs of increased androgens, whether in the males or in the female. But at the same time, you will have less glucocorticoid and mineralocorticoids. But that's going to be mostly what? Okay, what if I say that we have congenital adrenal hyperplasia, too much testosterone, but at the same time we measure the level of cortisol and aldosterone and we found them normal? Why is the level of glucocorticoid and mineralocorticoid normal in most cases? Yes, exactly. This reduced production at the first stages will lead to more increase in the ACTH pathway, okay, which could compensate for some way, but it might not be enough, okay? But if I want to treat it, how should I treat it? And if I'm giving fludrocortisone, for example, am I giving it as a replacement therapy or as something else?
هو مش ريبليسمنت، هو عشان تقلل الكومبليكيشنز.
Why? How?
لأنه النيجاتيف فيدباك راح يعمل عليه.
Exactly. So the major treatment for this is to give a glucocorticoid. And the glucocorticoid is using the function of the negative feedback on ACTH to just inhibit that pathway. By inhibiting that pathway, you can inhibit also the synthesis of testosterone. Okay? Now, do I need to give a mineralocorticoid in this case? No, mostly. Why? Because we said that most of the negative feedback is derived from glucocorticoids and not from mineralocorticoids. The only time we need to use a mineralocorticoid is that when we have an obvious, an overt decrease in the level of aldosterone that's going to lead to salt wasting. There's too much excretion of sodium, okay, and water, and the patient might get into a state of dilutional hyponatremia. In that state, you need to use a mineralocorticoid. Okay? So glucocorticoids in this state is not replacement. It's going to act on the negative feedback pathway. Mineralocorticoids are not used all the time. They're only used if the patient has too much reduction in the level and function of aldosterone that will lead to salt wasting. You got it? And finally, because I like CBS, fludrocortisone has been recently introduced as a treatment for something called postural idiopathic postural hypertension. Which means what? We have no idea why that happens. It happens a lot. Not a lot. You find a lot of people who have postural hypertension without any cause. There is no obvious cause for their postural hypertension, particularly females. So in that case, fludrocortisone has been recently introduced as a management line for the disease because it's going to work on the sodium and water excretion, making retention. Fine. The final thing we need to talk about, and that's because it's included in your objective, is to give an idea about the mineralocorticoid receptor antagonists. So we talked about the treatment of the deficiency, which is to replace. And now we're going to talk about the antagonists, which will be used in the treatment of excess. Okay. طيب. Have you heard of any drug that has a mineralocorticoid receptor antagonist? Great. طيب. And that's the first drug which we will discuss. I guess you have already studied that previously. Supposedly, you know some information about it. مين يحكي لنا شوي عنه؟ Yes. ليش؟ Why? Okay. Good.
Reload of the heart.
Good. And there's another added advantage we talked about previously, which is the structural remodeling of the heart. That's going to involve aldosterone function. So when you give spironolactone, it's going to act also on that. So it's both as potassium sparing and also as an anti-remodeling agent. What else? It will block the mineralocorticoid receptor. So everything that's related to aldosterone will be blocked. But what's more important? What about hypertension? Could you use it in the treatment of hypertension? يلا يا اخوان. متوسم في خير مش عارف. شباب. In the treatment of hypertension. واللي يعرف احكي لي.
لا
والله ما فهمتش الجواب. ولا لا؟
لا طبعا.
هي عكس الالدوستيرون.
تمام.
لا لا
لا مش هستخدم.
لا لأنه كان بيطلع 5% كأنه أو شيء contributed to
Okay, so that's, no, we cannot say it cannot be used. It cannot be used as a monotherapy for hypertension because the percentage that it will reduce in the sodium and water reabsorption is only 1 to 2%. Okay, so where should we use it? When do you use it in the treatment of hypertension?
مع شيء ثاني
ليش؟ في مدام واحد
عشان الكاليميا.
Exactly. So it's an add-on therapy for the other diuretics who cause hypokalemia to spare the potassium from excretion. Okay. Type. One thing that will be added as a new piece of information today is that spironolactone is not a great drug in one sense, which is it's a dirty drug. We're giving it as a receptor blocker for mineralocorticoids, but what happens actually is not that only. It also goes and blocks the androgen receptors. It can go and block the progesterone receptor, and it could also go and act on the biosynthesis of these androgens and progesterone. So it's not ideal. Okay? But why is that important? So what if it blocked the androgen receptors?
Sexual affinity.
What do we call this? The anti-androgenic side effects are going to prevail. So whenever you give spironolactone, the first thing to think about, and you have to communicate well with your patient, is that anti-androgenic side effects are not uncommon, and you might feature some of these side effects. I'm going to show you in a minute. Okay, so it could also block androgens and progesterone. It's used in hyperaldosteronism. It's a potassium-sparing diuretic, so it's an add-on therapy for hypertension to counteract the effect of other diuretics on the potassium excretion. It's used in hirsutism. Why? Yes, because it blocks the androgen receptor, so it could be used in hirsutism. It's used in heart failure because, as your colleague said, first off, it acts on one of the compensatory mechanisms going wild, which is the RAS system, and the other thing is that it's going to inhibit the cardiac structural remodeling. And finally, it's preferred mostly in ascites of hepatic origin, and we have discussed that previously. And why is that? Because the ascites that's related to cirrhosis or whatever was found to have high aldosterone levels. And that's why when you want to give a diuretic in the cases of ascites of hepatic origins, do you think of furosemide or hydrochlorothiazide or spironolactone? Yes, although the efficacy is not that great compared to that, but because there's too much aldosterone in these patients. The first side effect to think about is yes, that's the most important thing. Hyperkalemia is the most important side effect of spironolactone, but the others are the anti-androgenic side effects, and these include, as we discussed multiple times, this thing, which is gynecomastia. The second thing affecting the libido and sexual drive in both males and females. Nice. And finally, menstrual irregularity. Okay? This, for example, is a very common side effect of spironolactone. So you have to communicate well with your female. If we get a drug that's very dirty, what should we do as scientists? Try to find another one, acting on the same general principle, but at least it's going to be more selective. And this is what they have done. They introduced another drug, which is Aldosterone. Okay, it's another mineralocorticoid receptor antagonist, but this time it has a very, very minimal, or that's what the pharmaceutical companies said. They have very minimal cross-reactivity and blockade of both the androgens and progesterone receptors. And that's why it will have less anti-androgenic side effects. So where should we use it mostly? Again, in the other things that's related to aldosterone hypersecretion, like ascites of hepatic origin, hypertension, and so on. Who has any questions? بقي جماعة الخير لازم تتصاحب. طيب لبين ما زميلكم يحضر حاله عمر انت معك البرزنتيشن؟ طيب شباب بس في سؤال صار لي على الايميل more than 10 times and it's about octreotide and somatostatin and how we can use them in VI program. So one of the things I told you is that one of the side effects of octreotide is what? Diarrhea. One of the side effects of octreotide is diarrhea. But at the same time, I said in the lecture, could be indicated in cases of secretory diarrhea due to VI. How does that make sense? Okay, so the explanation for that, octreotide acting as a somatostatin analog, it acts to inhibit VIP, which will decrease intestinal blood flow and it will decrease gastric emptying and the smooth muscle contraction. So the first side effect to expect of octreotide is what?
Constipation. Malabsorption.
لا قبل malabsorption.
Constipation.
Constipation. And this is exactly what happens usually. It starts with constipation. But that does not last for long. Because the second thing to expect of octreotide, it's going to introduce a state of malabsorption. And malabsorption will prevail. And the first features of malabsorption will be what? Diarrhea, steatorrhea, and flatulence. Okay? And that's why with octreotide, if you go to the textbooks, they will have side effects, constipation / diarrhea. It depends on the stage. Okay? So now it makes sense to use it in the treatment of secretory diarrhea due to VI coma. You got it? Great. Right. We said in the first lecture that I want some of you to come here and share the stage with me and introduce